Good afternoon, everyone in China, and good morning to all the colleagues in Italy. A warm hello to all the participants online from China and the Italian side. I'm Yining Wang, your host today. I'm a radiologist from Peking Union Medical College Hospital and Vice President of Youth Committee of Chinese Association of Radiologists. It's my honor to host the international exchange. Today, we are facing common issue worldwide, the COVID-19 virus breakout. After 3 months of fighting against it, China has achieved great accomplishment and taken the breakout under control. People are suffering all over the world, in Asia, as well as in Europe and America. Hence, under the lead of Professor Zhengyu Jin, the Chinese Society of Radiology has initiated this exchange program to share our experience through fighting with the virus and to help our colleagues all over the world. The program is exclusively sponsored by Bayer Healthcare and the Ultravist marketing team. We are also deeply grateful for their contribution and engagement. Without further ado, I would like to pass the microphone to our chair today, Professor Zhengyu Jin. Professor Jin is the initiator of this international program. He is the president of Chinese Society of Radiology, the president-elect of the Chinese Association of Radiologists, honorary member of various international societies like RSNA, ESR, FSR, GSR, JSR. Let's welcome Professor Jin to open this webinar. Please.
Okay. So, dear Professor Giovagnoni, dear Professor Nicola, Professor Xue, and Professor Yang, my colleagues, ladies and gentlemen, good afternoon. So, I'd like to talk with you about against the COVID-19 pandemic. So this is a very different, very special time for all of us. In this year, we are faced to a very severe situation with COVID-19 virus. So we are radiology in this fighting period is still standing in the very front of in this time. So we use CT scan imaging to help against the COVID-19 virus. So we also get some preliminary experience for against the virus. Especially in Wuhan and Hebei province. Of course, right now in Italy, we are also faced to the virus. So this is a very good time to have some cooperation to share the experience. In 2 months ago, our society, Chinese Society of Radiology, make or you can say the recommendation is for against the virus. So right now, I'd like to ask Professor Xue or Professor Yang to share the experience with our colleagues in Italy. So we, of course, gives a very big help for the clinician for how to guiding them to find out the patients and also in the working flow, we have the every segmentation. So this is very important. So we use a very special clinical pathway to help them find out the patients and follow up them. So this is very good. So I hope we can exchange the experience to help the global against the COVID-19 virus. Of course, I know our colleagues like Professor Giovagnoni and the team get very excellent experience in this time. So we'd like to share the experience with you. If you need some help or some needs, just let me know. We like to fully support of you. Of course, I like to thank very much about the organizer biopharmaceutical to organize this meeting, give a chance to discuss with all of you. Hope everything is better. Wish you have a very nice situation and hope everything is better. Thank you very much.
Thank you, Professor Jin, for your inspiring speech. We are very glad to see that the Italian Society of Radiology is very enthusiastic about this exchange. Let's welcome Professor Andrea Giovagnoni as the representative from Italian Society of Radiology. He is the president of Italian College of Academic Radiology, the president of Italian Radiation Oncology and Nuclear Medicine, executive committee member of Italian Society of Radiology. A warm hello to you, Professor Giovagnoni. Please.
It's a great pleasure and honor to participate in this webinar with the Chinese friend of the Chinese Society of Radiology, and we have also thanks to Bayer to support this very important scientific initiative. On behalf of the president of our society, Professor Grassi, and the entire board of the society, it's a very pleasure to give an occasion to spread our experience. This is a dramatic experience in terms of outbreak in the COVID-19 in this particular period. I have some slide to share with you just to introduce okay. It's okay. Well, here. Okay, just to introduce the activities of the CIRM. CIRM, as you know, is the second largest radiological society in Europe. Was founded in 1930, more than 100 years ago. It is a scientific association which is membership include the majority of Italian radiologists, counting about 11 members. We are some half and half male and female, and most of the members as a young member, as you know, and especially in the last 10 years, the number of young radiologists grow up very fast. This is very important because in this manage this particular outbreak, because the CIRM is general structured in 18 regional group. This is the national coordinator, is the chief department. Professor Carafiero is chief department of radiology in Milan, as another very dramatic hot area to manage to afflicted by outbreak COVID. The division regional group was very important to share knowledge, to share the activity, to share the statement of the society that was important. Even in the start of the 2 months ago, on the start of outbreak, the homogeneous behaviors in the radiology was a dramatic situation. Remember, 2 months ago, we received 30, 40 patients a day, even in our hospital, with a dramatic reorganization of the entire radiology. CIRM even is structured in 20 scientific colleges with a subspecialty section coordinated by Professor Gandolfo, is Chief Radiology in Genoa Hospital. Group session organize annual meeting and share knowledge and share activity. In this particular cases, the subspecialty at the College of Thoracic Radiology that was coordinated, the president of the Nicola Sverzellati is a chief radiologist in Parma University that play a central role in to share the knowledge, especially in this particular case, is to homogenize activity and the modality to study patient with the X-ray and the high resolution CT. And the easy experience will be very important for the successful of this webinar. Even the scientific journals, you know, CIRM published 2 journals. I have the honor to be the editor-in-chief since 80 years, 90 years this year, and probably next year I will leave my duty as editor-in-chief. But the big one is the Radiologia Medica is published, is PubMed cited journal in English with quite a light impact factor, and the second one with the Journal Radiological Review devoted to educational purpose. It's a very important support to activity of the main scientific journal. Even the journal was important to manage the outbreak in order to spread the knowledge, to spread the behavior, the statement of the CIRM of the all member, and not only on the member, because in this period, the organization of the webinar in general, the activity was a little bit modified, of course, with the webinar modality. I just want to present our learning center around the Italy, the first one, the biggest one in the Rome, but we have also a webinar, a learning center in Milan, in Sicily, in Sardinia, just to have the possibility of all members around the country to participate with the same possibility of the webinar. In this particular period, especially in outbreak period, we have organized the 49th Congress of Italian Society of Radiology that will be held in Rimini in the next October. We hope to participate with the same modality, but now we have no the clear idea, but we hope to present the Congress to have the possibility to meet, joint all radiologists. In general, at the Italian Congress, we participate in general more or less 5,000 members. In this particular period, probably most of the activity will be devoted to the outbreak management. The last one is the international activities. CIRM established scientific relationship with some of the most important radiology societies around the world, and it's a pleasure to show and to share with you some pictures, some slide of the last CCR in Beijing last November, in which I was a very pleasure to be invited to have a conference to participate at the international group as a representative of the most important international society of radiology around the world. Just to indicate it to me, it was a very pleasure, very fantastic congress in November, and my hope is to participate once again in the more quiet period when our outbreak will be finished for this particular purpose. And I would like to thank again my friend, my old friend, Professor Jin, for invited to organize this webinar, especially with the Chinese and the Italy, that is represented two most countries around the world that have impact, the first impact with this dramatic outbreak that modify our style of life, modify our style of radiology modality in general, modify the general structure organization of the whole radiology into the hospital in general, the society. So probably we have to remind what will be the radiology after outbreak. Just today we have to have a meeting just to try to restart after the crisis, the peak of the crisis in the next 2 months, but it will be very difficult to become the normal before outbreak. Nothing will be normal after outbreak period, but all together we'll do it. All together we win this very incredible fight. Thanks for your attention at this moment.
Thank you very much for your introduction. And thank you for your warm speech. Today, we have 2 Chinese experts and 2 Italian experts presenting their experience regarding COVID-19 diagnosis and research. The first speaker is a great peer of mine, Professor Huadan Xue. She is the Vice Chair of Radiology Department of Peking Union Medical College Hospital and the Vice President of Youth Committee of Chinese Society of Radiology and youth member of Global ISSR. Let's welcome Professor Xue to present progress and the prospect on imaging diagnosis on COVID-19. Please, Professor Xue.
Thank you very much, Professor Wang, for your kind introduction. Hi, dear Professor Andrea Giovagnoni. So nice to meet you here. It is my great pleasure to share this topic here with Chinese radiologists together with Italian radiologists, just like Andrea just said. We are the first 2 countries that had the great impact of the medical crisis from the COVID-19. And so in the world, now we have a great wave of COVID-19. And back to the early December of 2019, a series of, as no one knows about this virus, a series of virus pneumonia cases of unknown cause at that time emerged in Wuhan, Hubei province in China. This virus, now we all know that it is a novel type of the coronavirus family, which is named 2019 novel coronavirus by WHO in January this year. Well, and the infections that caused by this virus is now called COVID-19, as we all know. So now WHO had declared the COVID-19 as a public health emergency crisis of international concern because of its rapid break in many countries. And so today we'd like to share some experiences that we had from the Chinese side, and also we would like to have experiences exchange from the Italian side, as the two chairmen mentioned. And so my topic will focus mainly on this 5 background, the imaging manifestation, the presentation in some special populations, and also differential diagnosis, and also, of course, the CT value. How, why, how, and what can we get from CT? And so for the COVID-19, we know that it's, now we know that the infection source mainly is from the patient with or without symptoms. And so now in China, we have this new topic about the patient, the potential, the population who are now without symptoms is still the potential dangerous for the entire society. And so now we are trying to work on this new topic, this new question raised by the Chinese government. And for the routes of the transmission, mainly it's the droplets, like this 3 red arrows showed. But now there's also some publications and series about this aerosol transmission. And so if the virus can be transmitted by the aerosol, and then we need to take close mention about this possibility. And also the close contact might be another route of transmission. Well, the mean incubation period of time is 3 days, and as we all know that generally in all countries, 14 days is the deadline for the self isolation. But as we all know, as doctor, that the longest incubation period for this virus can be as long as 24 days. We had this kind of case. Not so many, but we had this kind of cases in China as well. Well, the main clinical symptoms for this disease is fever, but not always. About 15% there's no fever, cough, shortness of breath, and some patient will have diarrhea and abdominal pain as well. So for the how to confirm the diagnosis for COVID-19, we need to have the epidemiology, history, the clinical symptoms, the laboratory inspection, the etiology, and also we need to have this imaging manifestation. Although not all patients will have positive imaging findings in its CT scan, but CT is still one of the important diagnosis resource for the COVID-19. So imaging patterns may help to improve the accuracy of the diagnosis in general. Well, as we found, if there's positive findings, we should still differentiate the COVID-19 patient from other virus pneumonia, bacterial pneumonia, and so on. Of course, in this special period of time, especially for those patients with specific epidemiology history, with etiology or clinical symptoms, we should we should put COVID-19 as the first diagnosis. Yet in some other patient, we need to do the differential diagnosis, of course. And so, according to the diagnosis and treatment protocol of COVID-19 infection, the trial version 6 from our country, the government released which is released by the government. We in China, we put COVID-19 into 4 different types as its severity differences. And so if we look into the definition of these 4 different types, we will see that the position of the CT scan is very important, actually. So for the mild type, for those patients, they should have only mild clinical symptoms and without pneumonia appearance in CT imaging. Well, for the moderate type, patient should have fever, respiratory symptoms or others, and there will be positive findings in the CT scan, the CT image with the pneumonia appearance. Well, for the severe and the critical type, there's also some definitions based on the CT finding. As for the severe type, there should be faster progression on the CT imaging findings within 24 to 48 hours. And so, so as for the severity evaluation, CT should be one of the most important tools to do the patient classification. And for every disease, there will be a whole progress for the emerging and the peak situation, and then recovery, the whole pathway for the disease. And the same thing happened for COVID-19 actually. So the very first time, very beginning, we will have majority of those cases can be controlled with stable and improving medical conditions. But some cases they failed to receive effective therapy. They could reach their deterioration, and the changes will be rather rapid. And so lesions on CT will become more diffuse, distributed in a truly short term. And so for those early stage, for the cases in the early stage, we actually should take a good care. And then there will be the peak severity at about 10 days after the beginning of the disease. And then at about 14 days, with enough medical care and therapy, there will be improvement. And after that, there will be clinical cure. With this recovery situation, most of the people will have full recovery, or some people will have some small amount of residual strips in the CT imaging. Well, both number and size of lesions in lungs will decrease, and the density of the lesion will reduce as the patient move towards from the peak and to the recovery period. And then we will see the recovery on the CT imaging as well. The typical imaging manifestation of COVID-19 later we will introduce for that. And CT is, in our country, is recommended for the screening of COVID-19. As we all know that in the early stage, the only CT findings can be the GGO, patchy blurring with the blurring rim shadows. And so in this kind of manifestation, X-ray has little roles, and so in our country we use CT as the screening tool. Of course, everybody is concerning about the radiation dose, but in this severe crisis, we all agree that CT is still the first line choice for the beginning evaluation of the patients. And of course, chest X-ray still has its place in the whole pathway of the disease, especially the bedside X-ray for the ICU patient, the critical cases, especially for the follow-up evaluation. The HRCT is the best choice for detect possible opacities for those suspicious patients. And be cautious is that about 1/4 confirmed case with CT scan will show no pneumonia on CT imaging based on our previous publication from China. Well, and so talk about the value of CT in COVID-19. We can put it into 5 different categories. The first, of course, is the screening for the suspicious patient. Yes, CT imaging is very important for the screening, but there could be false negative patient. Saying false negative is actually pointed to the diagnosis of COVID-19. And so for this point, I've already mentioned. And the second one is the diagnosis. Once we found the positive findings, actually we needed to do the different cases without positive CT findings. So diagnosis, so we move to the third topic is the severity evaluation. CT is no doubt the first line tool to do the evaluation of the disease severity. And for the follow-up CT imaging can be of use, but X-ray can be the alternative choices. Well, for the prognosis, after the recovery from the disease peak time, we can use the CT imaging to help to decide whether the patient can be set out from the hospital. But for the prognosis, I mean the prediction of the prognosis, there's not enough cohort data to do the prognosis prediction, but based on the severity evaluation, we a promising or possible potential use for CT imaging to predict the prognosis. Well, the typical chest CT findings for COVID-19 is the unilateral or bilateral, focal or multifocal or diffuse area of GGO, and consolidation with subpleural, peripleural, or peribronchial vascular distribution. It can be also find with the crazy paving sign. There's also some atypical features that we can see in some cases, including the hollow sign, the reversed hollow sign, the cavity, small pleural infusion, mild pleural infusion, and also pneumothorax, and also the lymph node enlargement. We know that there's PE patients, I mean the pulmonary embolization patient happened in the Western country, but we don't have that many cases in China, and also in the Eastern countries. It could be the race differences, but we don't have publications for that point. Well, for the follow-up over time and the following treatment, the findings of fibrosis, including the architectural distortion and the peribronchial vascular thickening, may be seen. And as for the recovery patient, there can be the total entire recovery as a normal CT finding. So for the distribution pattern, if we look into the CT findings for the COVID-19 patient, we can put it into some small topics and to look into it in more details. Firstly is the distribution pattern. And so the most frequently seen distribution is the subpleural, like here, here, and or the peripleural at the lower lobe and the posterior of the lung. This is the most common findings. Well, sometimes, and this one is bilateral, multiple, and subpleural GGO. And so just as we mentioned, GGO is the, and also consolidation. GGO is like more mild and the consolidation is more solid. And so these are the most common findings in COVID-19 patient. Well, sometimes the inner zone of the lung can be also affected as this case. And this peribronchial vascular area sometimes can be also found in the not so many cases, but we can also sometimes see this kind of manifestation. Talking about the quantity of the range and the range, some cases show unifocal, just one lesion as the initial CT findings. Well, as we mentioned, if they encountered the disease progression, and then the unifocal lesion will increase, and there will be multifocal lesions, and then. And some cases will show multifocal lesion at the onset of the disease. About 70% patient had an involvement of at least 2 lobes. About 60% patient involved at least 4 lobes. And so we can see in these publications, severe cases is not so rare. And so we actually, at the very beginning of the understanding of the disease, we found that this disease is very difficult to cope with. Talking about shape and interface of the lesion, the most common shapes is like triangle, patchy, or cone shape, subsegmental or segmental. And so it can be small or big, but mostly segmental distribution. Well, sometimes we will see this mosaic perfusion pattern. And this is the holozyme, or sometimes you will see the anti-holozyme. But these two are the not the atypical findings of CT of COVID-19. And the interface between the lesion and the normal pulmonary is often ill-defined as the effusion of the pathology background of effusion of these lesions. And talking about the adjacent structure changes, the subpleural region may be spared. Like this patient, we see these cone, the triangle shape, the lesion. But if we look into the interface between the lesion and the pleural, and you will see a gap between these two structures. And so, and this one is also the lower right image. You will see the sparing of the interface between the pleural surface and the lesion. But the common changes of adjacent structure, including the thickening and or shifting of the pleural fissures, which means the lesion is actually more dry than we imagined. Although it's the GGO pattern, but because the pleural is dragged into the lesion, so we understand that this lesion as a dry lesion instead of a wet lesion. And so as we see that many patients have multiple lesions, and the lesion will have big or small scale, and so we in our country, many companies, especially the AI companies, helped to develop a lot of many softwares to do the quantitative evaluation of the COVID-19. This does help, and the initial publications also indicate that the ratio of the pneumonia volume to the entire lung can be used as a quantitative parameter of disease severity evaluation. And AI also help also helps for the entire process of the diagnosis of the COVID-19, including the scan, the intelligent scan, which indicate that you don't have to touch the CT scanner. You don't have to touch the patient to position the patient, and including the diagnosis and also including the severity evaluation. And so I think AI in this period of time really did a great contribution to the improvement of the whole medical process. So for the special population, especially in children, recently in our country, we recently see some news from, we don't know whether it's true or not, maybe Andrea, Professor Giovagnoni later, you may give us some introduction about that. We learned that there's some, the vascularitis happened, I mean, the higher rate of vascularitis in Italy in this young generation happened recently based on the COVID-19 or something. I don't know whether this is true or not, but in our country, we don't see that many cases for the child. And so as those cases, most children cases are from family cluster. And so, well, most of them, they have relatively mild symptoms, and they have good prognosis compared with the adults. And also, as our experience that the nucleic acid test should be examined with the anal swab rather than the throat swab, which is more sensitive in child. As for the CT findings, it could be variable and non-specific, saying that the differential diagnosis with other pneumonia CT findings. Well, the GGON consolidation is still, just as the adult cohort, still the most common findings in bilateral lungs. Sometimes we see the bronchial pneumonia in the children in the young generation cases, which is relatively a specific CT findings for this population. And also pleural effusion and the lymph node enlargement was not quite often observed in this cohort. This is a case from a child, 8 years old, female. We see the patient got the COVID-19 from the family, the cluster occurrence, and we found the bilateral here and here, a multiple subpleural, see next to the pleural, GGON consolidation CT findings. Well, after 5 days of therapy, all the lesions get smaller and lighter in density. And for those complicated cases, we don't have big study cohort on that. Although we all know that for this kind of patient, things can be even more difficult to cope with. And so, as our experience, the most common underlying disease, including the chronic obstructive pulmonary disease, the diabetes, the hypertension, the coronary heart disease, and so on. The ratio of the underlying case in severe group is significantly higher than that in the non-severe group. And so this is what we are talking about. This kind of patient also, sometimes when we have the background of the pulmonary disease, it could be very difficult for us to do the diagnosis as well. And patients with potential disease, especially from the immunodeficiency, are more prone for the infection. This is very interesting. And yes, there is not yet literatures about the COVID-19 imaging manifestations in this patient group, and so this is still a area that with unknown knowledge. As we mentioned, that we have other virus pneumonia for the humanity. While virus in the same viral family will share a similar pathogenesis of pneumonia, and so the imaging patterns will have distinguishable characteristics for the entire viral family. And so that means inside this family, the CT findings cannot be specific for the differential diagnosis. And so we will see the spectrum of CT findings that are classified into 5 categories, including the pulmonary, the parenchymal attenuation disturbance, the GGO, the ground glass, opacity and consolidation nodules, and tree in bud opacities, interlobular septal thickening, and also the bronchial and bronchiolar wall thickening. And so these are the 5 categories. And so, as we all know, that we have we have this family for the coronavirus, and including COVID-19. Besides COVID-19, we have SARS and MERS, which are the 3 most severe society medical crises in 2003, 2012, and this year. And so these 3 are all the worldwide crisis for the entire human beings. And so, but here in the table, we will see the differential about the differences between these 3 coronavirus. And so there's some mild differences between the 3 virus, though that we know that the SARS, for me, I'm quite familiar with that, because in 2003, I was a medical student at that time, the very last year, but I still can remember the death rate of the SARS is quite higher than the COVID-19. But it's easier to be detected because SARS will have shorter incubation time and higher fever. And so COVID-19 is more mild, but more potential and prone to be detected. And so there are some differences, and I won't go into details as the time. Which you will see the GGO as well, and also the hypersensitivity pneumonitis, and also the alveolar proteinosis. And so in these 3 diseases, which is not the infectious disease, you will see the maybe some clinical histories will help us. And also for the GGO appearance itself, there's some mild differences. As for the last one, the alveolar proteinosis, it should be a bilateral area of GGO with smooth interlobular septal thickening, and sometimes consolidation can be found. And also, the distribution of the GGO is more like the geographic distribution. And so let's go back to the COVID-19. And so after we learn about the CT findings for the COVID-19, and also a general differential diagnosis for COVID-19 based on the CT findings, we need to think about the value of the CT in the diagnosis of COVID-19 again. And so CT now, we all know that its position in the newest edition in China, which is a assistant diagnose reason, or the tools for diagnose. Well, the PCR assay is the gold standard for the diagnosis. But CT, once upon a time, was recommended as the major evidence of clinical diagnosis in Hubei province. This is a very special period of time by our government. In one of the previous edition in early February 2020. And then at the middle of February 2020, with the release of the next edition, this clinical diagnosis definition was eliminated by the government. And so why? I think it's very interesting for us to talk about that, to discuss and to know because from this way we can understand the position of the CT at the whole process of the disease. And so we know the PCR-assay and CT. For the value, CT should be recommended for the diagnosis to assist the diagnosis. PCR is the gold standard. Well, for the accuracy, CT actually have a higher detection rate, as high as 98% for the initial CT scan. Well, for the PCR, a single time. So in our country, we do at least do twice for each patient because of the high false negative detection rate of the PCR assay. And so actually, compare with these two tools for diagnosis, we will see the difference. Well, for the speed, the PCR assay now can be much faster, but at the very beginning, the PCR assay, the nucleic acid test will last long, so in some province, as long as 24 hours or so. Well, for the CT scan, it's very short. It takes about just 5 seconds to be done. And so patient will get the scan and then come back, and then we will see whether there's some positive findings. And so the operability, CT is easy to operate, but for the nucleic acid test, it's complicated confirmation process, the entire process, especially when we add the government process for the test sample. The test sample should be transferred from the hospital to the CDC and then backwards and so on. So it really takes time. And so at that time, if we go back to the time of the release, between the release of the 4th edition and the 5th edition at that time in China, there was far more patients waiting to be diagnosed and isolated in Hubei province than the clinical available PCR test kits. And so that means there was a long patient waiting list outside the hospital who needed actually to be sorted and to be treated at that time in Hubei province. That means if we do not give them on time, if we do not give them a sufficient medical care or therapy on time, and then this patient could get a peak for the disease. And so those with typical CT findings, among them, under the guidance of the 5th edition, they received the timely medical care. This also helped to maximally reduce the risk of community cross-infection. Well, after 2 weeks at that time of the release of the 6th edition, those big bunch of patients with suspicious COVID-19 infection were successfully collected into a hospital already. And so in the 6th edition, the definition of the clinical diagnosis was canceled. And so when we moved from the big pig, and then we get rid of the clinical diagnosis definition. And so I think that's pretty much the entire information that I would like to share with you. And so as the conclusion, the CT imaging findings should not be used as the gold standard of the COVID-19 diagnosis. However, it still plays a great role in detecting pneumonia existence, assessing patient disease progression severity, as well as monitoring treatment response, although X-ray sometimes is more helpful. Well, for the patient with underlying disease, we not yet have a big cohort, and so this still can be investigated comprehensively. And also multi-center study should be performed. Thank you very much. I think we human will succeed eventually, and united we stand. Thank you.
Thank you, Huadan. That was a wonderful and very comprehensive interpretation of all the common appearance and the diagnostic key points regarding COVID-19. Next, we are very honored to have Professor Giovagnoni sharing his experience. He will be presenting about the general situation in Italy and SRRM activities on COVID-19. Please, Professor Giovagnoni.
Okay. Sure. Okay. No. Sorry. Okay. Should be. Okay. It's okay? Yeah. No. Huh? Okay. It's quite difficult to present a very complicated situation in Italy. As you know, this is the map of the spread of the infection in Italy. Most of cases or infected cases outbreak will be started and now continues in the north of Italy, especially in west of Italy at present. This is the general number. It has more or less 200,000 positive people infected, but it's incredible number of deaths as today is over than 27,000 people. And this is a very dramatic situation. As you know, the outbreak started more or less around the Milan area in Brescia and in general in Lombardia region is moved to the south of Italy, especially arrive Ancona is there, is at the point black. That means that the very high number of patients compared to the general population. We live in a very quite small area compared, for instance, to China's people. Italy, as you know, is a 65 million inhabitants, more or less, and Lombardia is more or less 11 million inhabitants in the region mark where I work and I live is 1,500,000 people, but compared to the number of cases, the percentage is it's a hot area, is considered hot area. Another point to be underlined is the very high number of health workers infected, more than 20,000 people. That means that at the start of the outbreak will be some problem in terms of the protection of the health workers. This provoked 152 physicians dead, more than 60% general practitioners, and is that one colleague coming from this area, this region, is a friend of mine, is 67 years old radiologist in activity, is died last week. That even the radiologist is involved, is strictly involved. This is the general situation. I presented the number of my region, but it's very similar to the center, the south of Italy is quite different. The Lombardia and the in Piemonte area, in the north and northwest, which is the curves of the peak is arrived about 20 days ago, and now the number of cases, fortunately, decrease every day. Yesterday, the total number in my region was 35 new cases, but in general is approximately the 2.5% of the entire population. What's serum activity in COVID outbreak? The first, just at the beginning of the outbreak, the first idea of the entire board of direction to implement the website, what different part was dedicated in English part, and we divided the activity of the CIRM to support the member in to manage the outbreak in technological scientific support and the professional support. What mean technological scientific support? We share with the other member radiological procedure prevention. We have the series of different procedure of the different big hospital which manage at the first with a very great experience in manage the outbreak, but even the statement of the international society like the Journal American College of Radiology or the Chinese Society of Radiology or the other general society, in order to have a share of the knowledge and even of the behavior for the protection, just to reduce the risk of contamination in the health working. In my hospital, I stricted observation of the prevention procedure. I had as a consequence only 2.5% of the health workers in radiology department involved in infection. That means that in the practice, just one radiologist, an interventional radiologist, was suffered for the pneumonia. Even 6 people around the other health work had positive at the swab, oral swab, but they have no symptoms, serious symptoms. It's very great, successful in general for the radiologist, for our department. Another very important part of the support, the technological scientific support of the CIRM was the structural reporting. In my opinion, in general, the opinion of the board of direction of the CIRM, structural reporting is a very important way to have an homogenization of reporting into the hospital and to share information, to create an Italian database in which to have the more important data to follow the patient after the peak of outbreak. This is the website to the link to have the structural reporting used. Another very important successful idea was to collect the cases of the member of the CIRM member in Italy. And we have collected more than 200 cases, a case report in which each group share experience, share particular cases. Well, this is very incredible success, the corona visible Italian radiological cases. And we present the first cases coming from my hospital. It's a typical, a very dramatic situation at the beginning of the activity, at the beginning of the March, in which we have a very, like a tsunami, in which 30, 40 patients a day arrive in the hospital with severe symptoms and severe pneumonia cases. Even in technological support was promoted by the publisher of the first experience with the low dose, low pitch dual source CT. With this particular approach, we have reduced, with the share with the other member, we have reduced the dose about the 60% compared to the normal CT, to reduce the possibility of the movement, especially in cooperative patients. This was a very important way to study a very, very high number of patients. The other, we could discuss about the role of CT in screening. I have some in discussion probably some problem related to the use of the CT as a screening, but one way to dramatically reduce of the dose could be a very important role to increase the number without any problem in terms of radiation exposure, or the general population radiation exposure in this particular case, even for follow-up of the patient. Because another point to be discussed probably in the last part of this meeting is the role of CT in the follow-up of the patient after the peak. And the second part is the gray zone, or the gray patient in which the swab was negative and the CT finding is very positive, or very pathognomonic for or indicated COVID pneumonia. It is a very particular difficult area. We have discussion about that. The technological scientific support of the CIRM is also increased with a divulgative video with a CIRM channel. This is the president in the main network, on Italian network TV, which spread the role of radiologists in management of the outbreak. This is an international program in which the radiology probably is quite obscured, but in this particular cases, radiology play, as you know, a very important role in diagnosis, in the follow of the patient during the critical care phases, and even will be important in the follow the patient for after the recovery. Another is the webinar. I present this webinar. It's a successful webinar, but we included many webinar activity with the other society or the other part of the subspecialty college in Italian. CIRM president support was another part of the CIRM activity in general, with the professional support, with a letter to the president to have a real psychological support to the incredible job of the Italian radiologists in general, in the hospital, in the big hospital involved, but even in the small hospital in the south, in which fortunately, the number of cases is very low compared to the general population, in which the outbreak doesn't represent a real serious problem compared to the North Hospital. And this is the first letter of the president, the board of direction, when I wish you the best and I'm proud of you, because even in these cases, a radiologist was fantastic in each hospital. What is support even for the another part of the radiologist, the syndicate, thank you for your effort, and this is a very important part. Even and my support of the radiology editorial, the chief editor-in-chief of the journal, I presented face to COVID emergency we do, and just at the beginning is very important to psychological support and to share that all society is very close to the job of the radiologist, and that all together we can overcome this challenge. An important data to be presented, to be shared, is the log to CIRM website. We obtained an incredible number of logs in the last 2 months. The number was 476,000 logs. It's incredible. Most, 86% is a new visitor spread around the world, not only for the Italy, but even in the Turkey, United States, and so in the entire Europe. This is what the successful activity of the CIRM that allowed to obtain the sharing of information in the country like France or the other country in Europe, but not only in Europe, especially at the beginning of the outbreak out of Italy. As you know, Italy was incredible, the second country in the world that was dramatic management of the outbreak after China. And this was a best way to share knowledge. I present this very important Chinese support. I remember the March 60, this letter coming from Professor Jin, the personal mail in which the Chinese Society and personally Professor Jin support our activity and have all support and all exchange for share information, share activity, especially to reorganization of the department. That is, in my opinion, the most important thing after the technical aspect of the pneumonia feature. To preserve our health worker and our colleagues, our radiologists, our technicians, is to represent the most important things for the chief department, but not only on the entire community of radiologists in Italy and around the world, because we are suffering from, especially in the north of Italy, a very incredible number of workers infected. So at the last of my presentation, I would like to thank once again the Chinese Society of Radiology, Professor Jin, and the old friend, the Chinese friend, to give us these opportunities. I think that the webinar is a very easy way to share and to discuss, especially in this particular time, in this particular experience of our life. Nobody I know imagined 2 months ago that our life is completely reversed, upside down, without any effect of the family, of the work, of the relationship. Is modified, dramatic modification, especially increased with the lockdown. The next Monday, we have stopped with our lockdown after more or less 2 months of lockdown. But the risk is that, once again, to increase the second peak of outbreak, and it's my opinion and my behaviors into my department, it has more care to open the activity very, very quiet to avoid the risk of the infection of the population, the infection of the patient, that coming to create a more safe job, a more safe activity into the department. I would like to thank again all participants and all colleagues for this opportunity. Thanks.
Thank you, Professor Giovagnoni. This is really a great job that SRM has done for Italy, and we see a lot in common with CSR here for China. Our next Chinese speaker comes from the city Wuhan, where the situation was most serious. Professor Fan Yang, she is the Vice Chair of Radiology Department in Union Hospital Wuhan, and the Vice Chair of Breast Imaging Branch of Chinese Society of Radiology. She will talk about her valuable experience for Radiology Department, infection prevention and work protocol. Please, Professor Yang.
Thank you, Professor Wang. Okay, moment. Is it ready? Hello? Could you see my PPT? Hello?
Yes, we can see your slides.
Yeah, thank you. Okay. So it's really my pleasure to be here to give some our limited experience about the prevention and how the workflow changes in my department during the outbreak of the COVID-19. And when we talk about prevention, I think first of all, we should think about separating. For me, I think the separating actually is the most important things of when we talk about the really protection. And it's very important to separate the infected and non-infected people and at the beginning, and then that will give you a bigger advantage for the others work. When we talk about infection disease, we should think about it's always combined with about the crowded people and especially the crowded travel. When we back to 100 years ago, there was also a big problem for the human beings. It's flu 1918, and there are photos from this from just to different area, and you can see, but the same is crowded people during the crowded travel. There's a crowded people, and then there should be close contact, and this is the reason the disease was more easy to be transferred. So I think for most of the medical staff, this is really true, the first true, and less crowded and actually less infection. And this is the situation in our hospital's emergency room, and there's a lot of people there, infected and non-infected, their family members, all of them there. And when we realized that there's the outbreak of COVID-19 in Wuhan, actually then we reformed our emergency room at that time full of the fever clinic patients. We use a part of the lobby of the hospital here. You can see this is the big lobby, and we separated it. This area is very near the emergency room, and then we give some things to separate it from the normal lobby. And after that, it will be, the situation is far better. And this is the drawing about how we reformed our fever clinic from the emergency room. Normally, it's not separate so clear, but when we realize this is infection disease, we separate it, reform it and separate different area, use different color, you can see. And after, so this is what I think when we talk about prevention. And first we should think of, as far as we possible, to do something about separate the people who have already infected and not infected and suspected infected. This is very important. And when we talk about the prevention, we should realize that there's a lot of prevention things. Some things is about control individual, something is about the control environment. This is different. For the health care workers, there's two kinds of contact which can make the transmission happen. Is contact with patient and contact with incubation carrier, and both is dangerous for the health workers. There's a lot of consequence from different country, and from different country we have different, even the different area we have different guideline. I think for most of the radiologists, we should study it and you realize every situation you will meet. Something looks very small, but when you face it in your situation, maybe it's very dangerous. So we should read more about this, all the guidelines, especially about the patient safety and staff, and how to protect your radiology staff. In our department, I think the first thing actually is the rule making and the knowledge about the anti-COVID-19 education to prevent the infection in response to the COVID-19 outbreak at that time. all the radiologist department staff, including radiologist, technician, nurse, register, and the cleaning staff, engineer, everybody in our radiology department should be re-educated about the knowledge of the virus actually. And this is some rule in our department. This is all in Chinese character. I try to give the translation about that. In China, we give the protection for the several grading. For the first grading, it's used for very, very dangerous situation. At that time, you have more PPE. And for the second protection, for the second grading protection, that most of the technicians of radiology department belong to this level. And for the most radiologists who just writing report and belong to this one. And during the outbreak of the COVID-19, I think the separate different area and different grading is very important, because at that time, the PPE material is very limited. We should plan about it and how to use it every day, use it effectively and feasibility. And also, when we talk about the staff education, we should use some very clear way. And this is some drawing from another Chinese hospital, the first Alfred hospital in Zhejiang. And they show some 7 steps before work. It's very clear here. And also 7 steps after work, and also 2 before and 3 after. All this have the small drawing, and it's very clear. And we will put it everywhere in our department, make our staff remember it and use it. And for the technicians who do the CT scan, it's very important to have the facial protection. It's included the goggles and also the mask. And it's very important to tell them how to use it in the proper way, and how to use, because at that time, the special mask for protecting medical staff is very, very limited, and we should use it really the right way. All this is the normal way, but what's more? Here I show you 2 pictures. One picture is also from hundreds of years ago, 1918, and it's a hospital. It's actually the makeshift hospital. This is another hospital. I'm very proud of it. It's in Wuhan area, not in the city central, but it's built just 10 days to finish that. And here I'm not mean the Chinese speak. This is also, we are very proud of it, but I should talk about something also behind this very fast speech. One I think is very important for me, that is I realized that how important the layout of a hospital is important, because you can realize this has a special shape of this the whole hospital. It's like a H. It's really like a character H, letter H. And here you can find why they have this kind of layout design. This is because this is the patient area, and both inside, in the middle, in the H middle, this is what doctors inside. And there's a channel across it. It's very close. It's very clean. And this is the, so use this kind of design, they separate different area and make it difficult to the transmission of the virus. And this is, I think, the really reason in this special hospital, because this hospital, all the patients in this hospital is very safe and is very, very sick. And working there actually is very, very dangerous. But there's truly 0 infection for the medical staff who work there. I think this is except the washing hand and using the facial mask, this is the truly reason. And another, which I'm very impressed, is about the independent ventilation system. And this is actually, use this system, you have the different air pressure rented in different areas, with the largest pressure in the clean area and the second semi-polluted area and the smallest in the polluted area. And such pressure environment, the air in the room can always keep flowing from the clean area to the polluted area and reduce infection. And this is, I think, maybe after this pandemic of the outbreak of the COVID-19, we should redesign as possible as our radiology department. Normally, when we design our radiology department, we just think about radiation protection, to think about magnetic field shaping. But after this, I think maybe in the big hospital, especially the big hospital like our hospital in Wuhan, we have nearly 5,000 beds in the whole hospital. We should really think about the safety of prevention of infection of medical staff and hospital when we think about the design of radiology department. When we talk about prevention, we also should pay attention about the high risk effects about in the department of imaging. One is the drop transmission during the communication for the doctors, especially the radiologist with the patient. For this, we call it 小一 doctor in cabin hospital. We try to use this QR code and we put it everywhere in the cabin hospital, and you can find that the patient was scanning it, and the medical staff helped them to finish it, the question inside. And using this way, we have a good effect about the communication with the patients inside the cabin hospital. This cabin hospital actually is very huge hospital. There's totally 1,500 patients inside. So, and use this way, there's no directly contact, and our radiologists know the exactly trouble about the patients inside. And another is about our technicians, is the contact transmission during the examination, especially during the CT examination. And you can find here, there is normally we have one technologist here doing the scanning, and another one who is inside the scanning room to put the patient inside the CT machine and then outside to there. And so you will notice that this patient, this technologist, she or she will contact with patient maybe which will be infected, and then come back to here. And so it's very dangerous, and this kind of transfer. And but also in this time in the big cabin hospital, we have some technique which can use some detector to put the patient automatically inside the CT scanner, which makes the contact for the technologies with the patient was to the minimal. And also we should make the experience exchange and study it from the other countries, other area. And this is the reason I always emphasize we should read a lot of papers during the work. There's a lot of papers talking about that. And for this drawing, I think is a perfect day, and different. There's four things for different things for the patient, for the medical staff, and for the environment. It's very good, so I recommend it. Okay, now we talk about the workflow in our department during this outbreak. Our hospital actually in this time we have together 5 areas. One is in the main hospital. We used about 300 beds for this kind of infected patient. And then our 2 small hospital who was in charge also by the Union Hospital, the West Hospital, and another cancer center was for the government to use it for the design hospital for the NCP patient. And also we also in charge of 2 combined hospitals. So when we're facing so many patients, every day we nearly have 600 to 800 CT scanners. And during the whole break, we have more than 50,000 cases together of CT and the DR examination. So when you face so huge work, and you know, for the CT scanner, normally 1 CT scanner, we have nearly 500 images to be reviewed. So you should really think about how to face this workload, the huge workload. And normally the workflow in radiology department is very actually complicated. There's many systems inside here, HIS, RIS, PACS, and EMR, and also modality and a lot of workstation. But during the outbreak of the COVID-19, we should reform it. Fortunately, this time we had AI really do some assistant work for our workflow. I think for the AI system, even it's not so good, the patient follow-up and for the clinical research, it's really useful. This, of course, this is my personal opinion. So first of all, I think it can maybe the lesion detection faster and more accurate. And for this, for the lesion detection, we can use the CAD system like the Siemens Palm 3D, or like the Siemens, or like the Philips, also the Palm software. This is actually not the really AI software. This is the CAD software, but it's still workful and it's certificated. And for the AI system, nowadays our department have together 6 different AI systems we have together to rebuild it. And for the AI system, nowadays for the lesion detection and the sensitivity and specificities, I think for the normal COVID-19 cases, it's good enough. But for some special cases, still should be do something about that. And also the most important thing is for the quantitative assessment. Now use the AI assessment is be truly feasible and can be the real quantitative amendment. Here I'd like to show you some case. This is the case from actually February 15. And when the first CT scan finished, the lesion just in 2 lobes and very small. After 3 days, there is more lesions in more lobes. And also after 3 days again, we found that the area of the lesion is the change is limited, but inside the area, the contents is different. And here is very clear if you compare these 2 areas. And this is also after another 3 days. And this time I want to show you for the whole volume of the lung, the right lung and the left lung is different. And this is because the lesion infection involved different area of the lung side. So another assistant I think is about the structure report. I noticed that there is some special effort from the Italian. I just noticed that this sign, this is also from Italian. I think it's a really good work. It's very clear and it's very comprehensive. And also there's another country also do the same thing and use different way from Germany. And another company, they also do this kind of structure report template. And together they have five slabs, and you can finish it. And then after you finish it, you will have the complete the structure report. For my department, we used another system, but we use this system. We can all in Chinese character. It's very important for our clinicians. And also for the AI-assisted workflow, it will be more easy and effective for the communication for our radiologists with the clinicians and for the patients. And this is to use the 3D visualization of the ground glass and the constitution, use different color, and you can see together 5 CT scans. And at the beginning, the lesion was very small, and the color is just one color, and then there's more and more lesions and more colors inside. So this is why I think it's more easy for the patients outside radiology to really know how exactly the lesion was. There's another way. We use the mixed reality AI technique to show the lesions and the whole lung size. And I think this is maybe particularly suitable for the medical students' education in the future. At the end, I'd like to show you 3 posters, which from the Ukraine. I found it's very, it gave me a really impressive, and this is, I think, this is the human beings culture. And when we're facing the same problem, I think at the end we will face it, and everything will go back to the normal. Thank you. Thanks for your kind commentation. Okay.
Thank you, Professor Yang. This is really helpful in real practice. I've also learned a lot. And then we are very glad to welcome an expert from a hot area as well, Professor Nicola Sverzellati from Parma. He is the chair of the unit of Science Radiology, Academic Hospital of Parma, president-elect of the Italian Society of Medical Radiology, and the past president of the European Society of Thoracic Radiology. Parma is a city in Italy, can be somehow compared with Wuhan in China. Professor Sverzellati has brought valuable cases to present and discuss with us. Please, Professor Sverzellati.
Good morning, everybody. Good evening. So let me share the screen first. Okay, I'd also like to thank the Chinese Society for inviting us, and of course the Italian Society of Radiology for giving me this opportunity today. So before discussing the cases, I like to try to figure out the histologic radiologic correlation in COVID-19 pneumonia. It's really just a matter of ground glass consolidation. So I will briefly go through the available data, pathologic data. It was reported that diffuse alveolar damage is an established feature of COVID-19 pneumonia, and diffuse alveolar damage was observed in postmortem biopsy in some individuals who died from severe COVID pneumonia with ARDS syndrome. And I'd like to remind you that diffuse alveolar damage is the worst, is the most aggressive reaction pattern that may occur in the lung. It may be secondary to several conditions such as idiopathic interstitial pneumonias, occupational exposures, infections, including COVID-19 pneumonia. However, diffusal viral damage may be also incidentally recognized in subjects undergone lobectomy for lung cancer, so it may represent also an incidental finding, suggesting that diffusal viral damage may be limited in extent, despite the misleading term diffuse, may be still localized and limited in extent, and may be barely asymptomatic in the initial phases. So some pneumonia may underlie some limited diffusal viral damage, and diffusal viral damage which may progress over time, so may carry a worse prognosis. So diffusal viral damage, as you can see here also, may be limited in extent in animal study, and was again asymptomatic, and the virus was recognized within areas of diffusal viral damage, which was limited in the left lower lobe in this case. But also acute unspecific bronchopneumonia was observed in postmortem autopsy, as shown in this case. So other findings were reported in these subjects. So,
sorry, Professor, to interrupt. You didn't share your screen. Okay, thank you.
Oh, sorry. So you missed all the images. Okay. So there was, so let me recap briefly. So what I said, okay, so you can see here what I mentioned before, the diffusal viral damage at postmortem biopsy in a 50-year-old man who died from severe COVID pneumonia. And that's the incidental finding of diffusal viral damage in subjects who underwent lobectomy for lung cancer, suggesting that diffusal viral damage may be also asymptomatic. And again, in animal study, an example of asymptomatic diffusal viral damage limited in extent. So diffusal viral damage seems the dominant, the most established histologic feature in COVID-19 pneumonia, and it usually quite aggressive, is the worst reaction pattern that can occur in the lung, but it seems also limited in extent and may occur in barely asymptomatic subjects. And you know that diffusal viral damage encompasses 3 phases: exudative, organizing, and fibrotic phase. But on the other end of the spectrum, you can also see some limited alveolar interstitial infiltrates characterized by lymphocyte, macrophages, and plasma cells. Organizing pneumonia may be supervening, but there are probably other further histologic abnormalities that may be seen in COVID-19 pneumonia that will be published shortly, such as acute fibrinolysis denied pneumonia, more aggressive form of organizing pneumonia, and in later stages, cellular non-specific interstitial pneumonia. And no question that we should not forget of the elephant in the room, namely vascular damage, which may be responsible, such a bad prognosis even in subjects with not so extensive COVID-19 pulmonary pneumonia. So all of these histologic abnormalities may give an explanation of the variety of the heterogeneous appearance that we see routinely now in subjects with COVID-19 pneumonia. Let's think about the multiple features associated with organizing pneumonia, which also may encompass different phases. So the features of organizing pneumonia may vary over time, depending on the disease stage. And the variety in disease behavior, which is quite challenging to predict at presentation. So many factors may contribute to this variability in the appearance of COVID-19 pneumonia. Features of organizing features previously nicely shown. And I like to emphasize the most specific feature to me, the perilobular pattern. So it is very important to identify these arcade-like opacities at the periphery of the lung within a ground glass opacity. These opacities are highly suggestive of organizing pneumonia, and are very, very helpful to differentiate between COVID pneumonia and other disorders, particularly other infections. Probably reverse halo sign should not be overcalled, probably is less specific, and you should pay attention between a true reverse halo sign and a kind of halo sign that can be observed also in pulmonary infarct secondary to pulmonary embolism. And you know that the frequency of imaging findings also depends on when infected patients are scanned, are imaged. In fact, it is worth bearing in mind that imaging is a single moment through the clinical path. And you can see that in this study, a majority of patients had a negative CT during the first 2 days after symptom onset, and opacification, such as consolidation and glass, usually develop between the day 0 and day 4, generally after day 2, after symptom onset, and peaking at 6 to 13 days. And in later stage, you can also observe some linear opacities. It is also worth noting that the disease may be unilateral and focal at the beginning, so mimicking other infections. So then over time, it's going to get widespread, more widespread, and for sure bilateral in distribution. So to summarize, here are the CT features of COVID pneumonia, ground glass, and consolidation. Occasionally, ground glass may be superimposed to interlobular and intralobular septal thickening, producing the so-called crazy paving appearance, crazy paving pattern. And the distribution of these abnormalities is generally patchy or diffuse. They are usually bilateral, but maybe unilateral in the early stage. They tend to be basal in distribution and mostly distributed at the periphery of the lung. More specifically, some opacities show some which is probably more specific, more specific findings compared to other infections. And it is quite important to recognize these suggestive features of organizing pneumonia. And I'd like to mention these dilated pulmonary vessels, also called fat vessel sign. We do increasingly see and notice these larger subsegmental vessels within peripheral ground glass opacities, probably suggestive of some vascular damage. And this might be also true for the centrilobular nodules, which may occur in 5 to 7% of cases. They are not trim bud opacities. Trim bud opacities are other findings suggestive of alternative diagnosis. So trim bud is a CT feature, a CT pattern against COVID pneumonia. Whereas these centrilobular nodules are solid in shape, are seen close to the vessels, tend to conglomerate, and they have a kind of polyhedral shape, and might be an expression again of vascular damage. And here are the CT features against COVID pneumonia for sure: cavitation, pleural effusion, which however may occur in ICU patients, the lack of ground glass, although this is not probably so reliable. So all of these findings can be also observed on chest X-ray. However, the chest X-ray probably is not so accurate to identify the most specific features of organizing pneumonia and all of these subtle features such as dilated pulmonary vessels and the differential diagnosis between centrilobular nodules and trim bud opacities and other types of nodules, of course. And ground glass may be also not visible on CT, particularly in the early stages. So there are several structured reports proposals in the literature. So of course, the structure report proposed by our society, Italian Society of Radiology, which is quite complete. This is probably shorter. The most recent one proposed by the European Society of Thoracic Imaging. And again, we recommend to describe all of the CT findings, specifying also the presence or absence of a CT finding suggestive of other diagnosis. It is worth reporting the extent of the disease, even without so sophisticated tools, so you can visually assess the extent of the disease. You can classify the disease as limited, moderate, and severe. However, there are no established thresholds in the literature, but it is still a worth exercise in clinical practice. And this information may be very helpful to clinicians to support the impression for these patients. And for sure, in conclusions, we are to report if the CT findings are highly indeterminate or non-suggestive for COVID-19 pneumonia. So I think you are all familiar now with the CT findings suggestive of COVID-19 pneumonia, and I will focus on them, the indeterminate cases. Here are some cases we presented with acute onset of symptoms at the University Hospital of Parma. Sorry, something weird is happening with my own computer. Okay, here's the first case. So you can recognize here some, at the basis, some fibrotic features. You can see some reticular opacities predominantly distributed in the superior regions. And this was a patient with known history of fibrotic lung disease, which presented with this supervening ground glass opacification. And here we are not sure. We've been struggling between superimposed COVID-19 pneumonia or other types of acute complications, such as other infections or diffuse alveolar damage, which may be also idiopathic or other causes of damage. It was quite indeterminate. And this was also true for this case as well. Again, another example of a patient with fibrosis at the lung basis. You can also see this widespread ground glass opacification. But here you can note these centrilobular nodules here and here, which tend to conglomerate. And they are irregular, maybe in shape, but do not show a tree bud morphology. So that was a case of confirmed COVID-19 pneumonia superimposed to lung fibrosis. And I think the most challenging diagnosis was, oh my God, the differential between COVID-19 pneumonia and pulmonary edema. So patients with history of cardiac disease came to our hospital, and this was a sizable proportion, or not a small proportion of cases we have seen, we've been reporting in March. And of course, pleural effusion is a feature against COVID-19 pneumonia, but you cannot be absolutely sure that these ground glass opacities represent pulmonary edema or COVID-19 pneumonia superimposed to heart failure or combined heart failure and COVID-19 pneumonia. So you have to point out this differential diagnosis. There's a kind of uncertainty, and you should discuss this case, case like this one, with the clinicians to figure it out. Now I'd like to show some more classic COVID cases, not so classic at the end, you will see. So here's the first one, a young guy, 42-year-old male patient with history of asthma, no fever. He complained cough in the last 3 weeks, and it was PCR positive. So swab test was informative this time. And you can see here on coronal CT image, is ground glass opacities essentially located in the right lower lobe. And you can easily see that this opacity shows, exhibits a kind of arcade-like appearance suggestive of organized pneumonia. but fortunately, this patient fully recovered after some therapy, and it was he went back home 4 days later. Another case of a young, 49, I would say young, yes, male patient with fever and cough in the last 8 days, admitted to our triage. Oxygen saturation was worse as compared to the previous case. Swab test was negative, and apologize for the low quality of this chest X-ray. However, these opacities were also visible also on chest X-ray, on frontal chest X-ray here in the right upper lobe. However, we obtained a CT scan which showed these ground glass opacities, sparing the very periphery of the lung. This kind of subpleural sparing is in keeping with organized pneumonia and non-specific interstitial pneumonia. Maybe you can also spot a kind of reverse halo sign here, if you believe. However, despite oxygen and antiviral therapy, 4 days later, he obtained another CT scan which showed worsening of the disease in extent. In fact, you can see that the glass opacities became visible also in the right lower lobe. However, after 10 days, he also recovered, and so a complete full healing was obtained for this patient as well. Here's a more complicated case. So he's a colleague of mine, is a physician working in the Parma hospital, 50-year-old male. He complained cough in the last 10 days, no fever, oxygen saturation was 94%, PCR was positive, quarantine, so he isolated himself. He's a physician, so his first initial CT scan showing his basal consolidation, and you can recognize again these arcade-like opacities, perilobular opacities consistent with organized pneumonia. However, on 12th of March, he came back with dyspnea, with left chest pain. Paradoxically, the oxygen saturation improved, so a small step from 94 to 96. And you can see that there's more consolidation here in the left lower lobe. It should not be core consolidation. In fact, there is the left lower lobe is reduced in volume, and this consolidation reflects atelectasis. So the proper term is atelectasis. So supervening atelectasis or worsening of the atelectasis with chest pain should prompt counter-CT study. Fortunately, we did so, and you can see here some clots, bilateral clots here in this segmental pulmonary artery and this lobar artery. And fortunately, again, he fully recovered after therapy. Another complication supervening in this patient with this very bad pneumonia. So respiratory, so at the beginning, it came with the oxygen saturation level of 92, so moderate pulmonary dysfunction, but respiratory dysfunction has been worsening over time, and we obtained a CT scan showing this diffuse ground glass opacification and atelectasis in the left lower lobe. And 10 days later, we obtained a CT scan. Clinical findings had been worsening and were quite unclear. We observed that the atelectasis improved, resolved actually, but we found some consolidation and 3 bad opacities in the right lower lobe, plus a hole, cavitation, a thick wall cavitation suggestive of superimposed infection. That was confirmed by EAL, which found some aspergillus. So that was a superimposed aspergillosis, airways aspergillosis. Here's the last case, probably not the last one. But I think this quite this imaging are self-speaking, speaking by themselves, and this is a more CT pattern more consistent with the classic pattern that we observe in subjects with ARDS. I mean, ARDS not related to COVID-19 pneumonia. He had COVID-19 pneumonia, and there are some basal consolidation atelectasis, dependent atelectasis, highly suggestive of the classic pattern seen in subjects with ARDS. And this kind of pattern is usually seen in subjects with lung with low compliance, higher lung weight, and they are quite responsive to high positive end expiratory pressure and proning. And I think the images after positive end expiratory pressure, high positive PEEP, and proning got some benefit. In fact, you can see that the consolidation here resolved, and also after proning the patient at CT scan, there is I think the basal consolidation and also the ground glass opacification decreased in extent. Conversely, subjects without this dependent consolidation, with another type, with another phenotype of COVID pneumonia, usually have less heavy lung with higher compliance, and these patients are not responsive, get not any benefit from proning from high positive end expiratory pressure. So instead, this kind of treatment, this kind of approach would be harmful for this patient, should be treated differently. And in this case, you can see that the ground glass opacities increase in extent, the first CT follow-up CT scan. And now the patient, recently the patient has started to recover, and you can see that the ground glass opacification decreased in extent, but you can also see some new reticular abnormalities and new irregularly dilated bronchi within ground glass opacity, suggestive of traction bronchiectasis. However, I do not use this term as traction bronchiectasis are permanent changes by definition, which are seen in lung fibrosis. So we don't have many information, many data about long-term changes. However, we are increasingly observing these supervening fibrotic abnormalities or residual fibrotic abnormalities in subjects who had bad COVID-19 pneumonia. So to summarize, I think there are several factors that can make our lives, our daily routine activity quite difficult. So the radiologist's interpretation of the imaging findings may be very challenging. And now radiologists in Italy are increasingly discussed when follow-up chest X-ray or CT is appropriate for these subjects. And interpretation of disease temporal changes should take into account of expected diffusal damage evolution, complications, and potential fibrotic response. Thank you very much.
那是说我一会儿打给你啊，稍等一下啊，谢谢。Okay, that was very interesting. Thank you very much for making the effort and sharing with us. Now, since we have presented 4 information-loaded lectures, if there's any questions, this is the time to raise your question. Please just type your question into the dialogue window and we will ask the speakers. And we have already collected some questions. First, Professor Huadan Xue, there's a question for you. In summer, can we open the air conditioner to do the ventilation because it was very hot. Would you please say something about that?
Yes, I think I think we should open the air conditioner. Yet we still need the ventilation, and we need to do the personal self protection as well. And yeah, I think we should do that. Yeah.
Okay, thank you very much. And Professor Yang, would you please open the video?
Yes. Oh,
Okay.
video.
Yes,
Okay.
there is a question for you. And good morning. There is a theory that states that the COVID-19 is not really a pneumonia, and the abnormalities that we see on the CT are rather the thrombosis of the small vessels of the lung parenchyma, as the virus targets the endothelial cells of the vessels. Do you agree with that, or you have any other idea about the lung parenchyma region, please?
Oh, it's really a very difficult question. I'm a radiologist who facing clinical case, and so I think this is maybe like a mechanism supposing, because in the clinical situation, I think maybe it's more difficult to prove that. Maybe it's at the beginning, I noticed that there's also a webinar from the ECR talking about the ACE2 target pulmonary damage, but I think in the for the human beings CT scanner, especially during the outbreak of COVID-19, normally we don't do the contrast agent injection, so just the normal CT, not the contrast enhanced CT. So I think it's very difficult to prove that the mechanism supposing, but maybe it's contribute some changes of this COVID-19 phenomenon. And also this is, I think, like a question about if there is some we call it community infection pneumonia is added for the virus infection, because some doctors insist on use some, especially drug from bear that actually we normally use for the community infection pneumonia, but it's very useful for some patients. So I think this is for me, I think maybe it's like supposing maybe you should prove it for the animal test, but for the clinic CT ability, maybe it's not can be proved right now.
Okay, thank you. Thank you for your answer.
Sverzellati， 不是还有一个？这个 Giovagnoni， 还有一个。他们就上面有好的，就随机我们还拉了一些人。
And Professor Sverzellati, there is a question for you. Are you performing HRCT follow-up the patients recovered from COVID-19 after hospitalization? And what are the first results in terms of features of fibrosis? Thank you.
Thanks for asking. No, I think we do obtain a follow-up CT scan according to clinical indications. We do not routinely perform a kind of screening follow-up CT scan to see if the there are some residual fibrotic abnormalities. So basically, we obtain follow-up CT scans with subjects who do have still some symptoms. So otherwise, in asymptomatic subjects who fully recover, we haven't obtained any follow-up CT scan so far.
Okay, thank you. Okay, there is a question for all the speakers. What's the opinion of you about the relationship between prevalence of disease and the CT accuracy? So from your point of view, what's CT and the disease prevalence is relationship? Thank you.
Okay. Who first? Okay, I will start. I think that this was a kind of potential distracting topic. We have been focusing too long on the lack of specificity of CT scan, the lack of accuracy. But as pointed out by a recent editorial by David Bruenke in Radiology, I think specificity and positive predictive value are highly related to the prevalence of the disease. So the specificity of CT scan was different at the beginning of March compared to the specificity we recorded at the end of March or the beginning of April. So the specificity and accuracy of any diagnostic test depends on the prevalence of the disease and on other factors. That is something we are familiar in clinical practice also for other interstitial lung disorders.
Okay, thank you for your answer. And due to the time limitation to our exchange has come to end today. And let's welcome Professor Jin to say something about this webinar. Please.
Hello, my friend, Professor Giovagnoni, Professor Nicola. So I think we cannot meet face to face. So very happy to see you here. I'm very apologize about I have a very emergent case, so I leave a little minutes. So Andrea, Professor Giovagnoni.
Yeah.
Can you listen me?
Yeah.
Still here. Okay. So our society is our Chinese Society of Radiology try to transfer some protection material to Italian Society of Radiology through the our friend Mr. Vaccaro Canapa.
Yeah.
But it's maybe have some problem, so it's still on the way. So I like to you and your colleague in Italy can get better and everything is good. So stay strong for all of you.
We appreciate your donation, your support. I know that we have some problem in transport, but we have a strict contact with Valtero. There are no problem about that. But we share your mail the last month, all friends, all members, just to spread your very kind effort for this. At the beginning of our outbreak, the problem of the protection of the health worker was a very, very big problem, especially in the north, and we appreciate very much your effort. And As you know, we are a very close friend, and we appreciate you. I received a message from Roberto Grassi, the president of the society, that followed this meeting, and they appreciate very much this initiative. Thank you very much again.
Thank you, Giovanni. So, Nicola, thank you. Thank you, everybody. So I think we meet each other in the WHO meeting.
Sorry?
WHO conference in that time is a couple of weeks ago. WHO.
Okay.
Online, I saw your face.
Really? Okay.
Yeah. So how in the future we can face to face to meet each other?
Yes.
I
in person. All right. Thank you.
Thank you very much. Stay safe.
Okay.
Bye.
Thank you. Thank you, all the speakers and all the audience. Thank you. See you next time.
Goodbye. Goodbye. Thanks.
Gracias.
See you. Bye-bye. Bye-bye.
Bye-bye.
Come si fa qui a uscire adesso?